Thank you for joining us so early this morning. We're pleased to announce that we have an AHA company, Mednician, to join us for the presentation this morning. We have live Steve and Dina. I'm Dana Malincrot from the AHA, and we also have Mara, who was not able to join us live today because she's taken ill, but she did record a full video as part of the presentation this morning, and I'll pass the mic to Steve. Thank you.
Thank you so much. So we have a little bit of a hybrid presentation this morning, and thank you for bearing with us. So my name is Steve Riley. I'm CEO and co-founder of Mednician. I'm honored to have someone who's been with me since we've basically started the company, Dina Becker, former president of ENA, our chief nursing officer, and we're very thankful to have our first, our original hospital partner and first site, the COO, Mara Bryant, be with us here via recorded message. So let's start this again.
Good morning, everybody. My name is Mara Bryant. I'm the operations executive at Adventist Health White Memorial, and that's in Los Angeles, California. I'm really sorry I can't be with you today. As you can hear by my voice, I am sick, and there was no way they were going to let me come play with you guys. So I do appreciate my co-presenters helping make this presentation happen, even though I obviously don't get to be there. But I think you're going to learn a little bit about some things we've been working on. I'll tell you a little bit about just my hospital in general, our health equity plan, some of our initiatives, and then a really deep dive into a very important initiative around our triage in the emergency department. So beautiful downtown East LA, if you've ever heard the song from Chi Chi Chong, Born in East LA, that's where my hospital is. So we're in East Los Angeles. White Memorial originally started as a storefront back in 1913 when Los Angeles had less than 300,000 people living here. As you can see, a little bit of our hospital now on the right-hand side. Now there's about 2 million people within 5 miles of our front door. So a very different population from when we started. We are an inner city neighborhood, inner city hospital. We're surrounded by residential, but they are inner city multifamily residential homes, multi-generational homes. So they're very densely populated. We have a lot of pollution in the neighborhood. We're kind of checkered with different freeways that surround all sides of our community. There's heavy manufacturing just immediately to the west of us. But we have a lot of small entrepreneurs in our neighborhood. So that part is really cool. We are part of a large Adventist health system that has 28 sites. We're a faith-based organization. And really, this is one of our mission fields in Los Angeles. I love this community. I love my community. It has a very vibrant spirit. I have a strong history of social activism, a strong belief in their faith and their families. So a little bit about White Memorial. This is our leadership system. And when I look at kind of being able to address health equity issues and being a good participant in health equity, for me, it boils back to that leadership system and making sure you have the right system in place so that you establish a trust with your neighborhood, a trust with your own workforce to make sure that you can do what is needed. So as you see on the right-hand side, that is our leadership system depicted. At the very bottom is our core competencies, one of which is partnering with our community. Serving the underserved is what we specialize in or what we do well. And then lastly, a data-driven excellence, pursuit of excellence is a huge piece of who we are. And those core competencies are born through to carry out our mission and our vision, along with our key documents that kind of govern all this work. So you can see in the center our strategic planning process, which produces our strategic vital signs, which is what we call our balanced scorecard, which also helps define and help us work on our workforce performance and how we manage those workforces, centered around our patients, and then managed at a high level around our organizational performance council. So that's how we're organized to really execute on health equity along with all of our other strategic initiatives. So one of the first things I wanted to talk about is, through our Baldrige journey, we really learned how to become very nimble around strategic planning. So up on the screen, you'll see our 8-step strategic planning process. We typically do a 5-year strategic plan, but we do 1-year updates to that. When it came to health equity, we really had to step back and relook at kind of how we were doing our strategic planning. And we worked to build more intelligence into key sections of our strategic plan. So, when we talked about future visioning, when we talked about our SWOT intelligence, and looking at our key measures, we built in health equity measures to help inform us and make sure that we were aware of those key things that were going on in our neighborhood, where our neighborhood needed help, and what role we could play in that. So I'm going to show you some examples of some of the data that we built into our strategic planning process. So we really looked at integrating community health and health equity into the strategic planning process. And we utilized, really looked at kind of all the data that was available to us, and also looked at the CMS categories and started to build a picture of our neighborhood around those categories. So for example, this set of measures was the beginning of the social and community context. So what does that look like for our community? You can see on the right-hand side, single parent households. 30% of my neighborhood have single parent households compared to 25% for LA County. Limited English proficiency is at 37%. So, it starts to build a picture of the community that we're serving in our neighborhood. We also looked at economic stability, kind of what does it look like to live in Boyle Heights? So we talked a little bit about income on the previous slide, but if you look in the upper left-hand side, in my primary service area, the median household income is $54,000. So that's average household income in my neighborhood compared to LA County at large, which is at $76,000 a year. When you look at those differences, and those of you who may know what it's like to live in Los Angeles, it's very difficult for people to make a solid living on $30,000, $40,000 as their total household income. And that's why you see multiple families living together and things like that. And then, that the graph in the center, children in poverty, at or below 100% of the federal poverty limit. It's almost 32% of my population compared to LA County in general at 18.8%. So we started looking at these key measures and, looked at them across the type of educational access the neighborhood has, the access to higher degrees, and then, lots of other measures that I know you are all very aware of. We built that into our strategic planning process so we could be more sensitive to what are the loads that our people are carrying that make health equity and community health tougher for them than maybe a normal suburban population. And then on top of that, we took our own internal data. So this is what we call our DRG matrix. And, I sit up at night worrying that I won't see something that's coming. And this is one way I sleep better, because every year I look at every single discharge I had across all of my diagnoses in the hospital. And I characterize them across 5 key areas. And then I compare myself to the top 10% of the nation in terms of complications, mortality, readmission, cost per case, and average length of stay. So we've been doing that a long time. But when we looked at health equity, we realized we needed to start stratifying this by more variables. So instead of just having it before, we would have our adult population and we would have our peds population. Now we're looking at these outcomes across race, ethnicity, gender identity, and looking at more specific age ranges to kind of isolate out some very vulnerable populations at the ages that we look at. So being able then to compare our outcomes in these key areas by diagnosis and then stratifying them by these other variables helps to give us a more robust picture of what's going on in our neighborhood and where some of the opportunities may be for us to do a better job. And I know all of us know there's a lot of people putting their hat in the game for health equity, and that's great because we need this focus tremendously. CMS came out with a pretty robust framework that they're encouraging us all to follow them as they take that journey. But those of you that are in hospitals know the Joint Commission also has a requirement around reducing health disparities. And then in the state of California, where I come from, we have HCI, who has their own California Hospital Health Equity Measure Advisory Committee. And they've come out with measures that they are requiring all the California hospitals to participate in 4 different areas. So there's some structural measures for the hospitals. There's core quality measures for acute care hospitals. There's some for psychiatric and some for children's. So in our strategic planning process, not only are we getting this picture painted for us, we have to also know where these regulatory agencies are sitting in these same areas, so that we are making sure that we're paying attention to those important things that we're going to be held accountable for, as well as what we believe we should be doing because it's the right thing to do. So this is what our current strategy map looks like. Like I said, it's a 5-year strategy map for us. We have one column that's just around community well-being because we believe that is so much about who we are. And in that particular column, we have categories of access to care, mental health. There's definitely a need for mental health outpatient resources in our particular case, food insecurity, and financial stability. So we have specific initiatives in each one of those areas, and the Community Wellbeing Council tracks these measures and tracks the progress on this part of our strategy map. So that's that red box outlining community well-being. And then on the far right-hand side, you'll see other ones. These are about the care we're giving inside the hospital or in our clinics. So a big push for us has to be the primary care expansion. When you talk about health equity, access is a huge issue for us. In our local clinics, it's easily 3 months out to get an appointment. So trying to expand access in a way that is sustainable over time is a huge part of our initiatives for our strategy map. And then in the area of high quality care, ensuring that we're really doing a great job of delivering care in those specific diagnoses or certain areas of patient safety that may be different than other hospitals would look at. So this is kind of what we're focusing on for this time period through 2025. And when I told you kind of how we cascade down our strategy map, once the strategy map is finished, then it becomes our strategic vital signs, which are the measurement, our balanced scorecard for our organization. In this year's Quality IQ, which is a publication we put out every year that outlines what we're focusing on, how we want to improve things, how we're measuring that improvement, and our performance over the last usually 3 to 5 years, how we've been doing in that area. this year we specifically introduced health equity as its own kind of force inside our quality IQ. And we have a logo that we utilize for the measures where we're paying attention to health equity or health disparities that we know about in certain subpopulations. So this particular booklet that we put out goes to every employee in our hospital, where we introduce kind of what we're measuring, what we're working on improving, and how that's going to work. And then I had mentioned about our community well-being council. You can see that on the upper left-hand side here. This is our governance infrastructure on how we run our organization. So you can see our legal board up at the system, our local community board, our foundation board, which is our philanthropic side. Off to the left from our community board, you'll see the clinical committee, the community well-being committee, and our graduate medical education committee. Those are all subcommittees of the board chaired by community board members who lead out very specialized work. And that part of the strategic plan that was under community well-being, this community well-being committee really delivers on that. And they hold us accountable for making sure we're doing what we said we're going to do and that we're doing it well. And then the lower structure is how we kind of function on all of our quality activities. So it's integrated in everything we do. Some of the refinements that we're working on for health equity, quite honestly, we do have a Center for Hispanic Health, which is a research group that we've been utilizing for probably about 5 years now. We believe we're going to ask that group to become our guiding force around health equity research. So we know where we want to investigate, where we have opportunities, how we actually do improvements, and then our ability to deliver on those. And additionally, our Community Wellbeing Committee put together a community advisory group of key community leaders that we need to listen to on a regular basis. And they actually come to my Community Wellbeing Committee meetings with the sole purpose of making sure we're staying in close earshot of what's going on in our community at any given time. So on top of all of that, Adventist Health has now, like many hospitals, have embedded a social driver of health assessment into our electronic medical record. It's a relatively new rollout of this particular tool. We had been doing it on paper previously, obviously not feasible when you're talking about large volumes. And then because our local ethnicity is very homogeneous, we're constantly having to compare outside of just our own data to understand the implications of the data for ethnicity. So we participate in several very large databases, one of which you'll be hearing about today with Kate AI, to be able to know how we're doing around the ethnicity profile that we serve in East LA. And then on top of that, we also are really embedding health equity measurement into our normal everyday measures that hospitals measure, like fall rate. We started to look at our falls and say, is there a gender issue on it? Is it an age issue? Is it a language issue that we are delivering care in a way that our population can understand it from us? So we have started working in all these different areas and have incorporated that into our daily report outs and our weekly report outs of our stratification on our data, so that we just become more aware of the potential areas where we might have health equity issues and health barriers that we need to be addressing differently. And this is where Kate came into play. So Kate is our artificial intelligence research project, and Steve will be taking you into this in much more depth. But Steve and I met many years ago, probably 6 years ago now, when we were trying to really address our front door of the hospital, which is triage in our emergency department. And really at the beginning, it was about making sure we were being safe. We're a high volume ER. There's a lot of volume blows through this ER every single day. And you knew that, triage nurses, they get tired, they get influenced by how many people are in the waiting room. And it used to just keep me up at night thinking about that someone could be in my ER, in my waiting room in my ER, getting sicker and sicker, and we weren't aware of it. And so we partnered with Mednition to develop Kate, which for us was just an incredible experience and project, and we had so much fun. But it allowed me, and it allowed my medical director, I have to tell you, to rest easier at night because of the artificial intelligence that's running. And it's, it is truly just like I say, a guardian angel for our triage nurses, so that they have someone else, Kate, who is also looking at the case, and will give them just little prompts that Steve will be telling you all about, and helping them manage a very busy ER and keep our patients incredibly safe. So I'll turn Kate and the rest of the presentation over to Steve. Thanks, you guys. Have a great time.
Great. Well, we're really appreciative of Mara for making that video. I've spent some time with her last week, and she definitely pushed through that. And again, she's an amazing person and leader in her hospital. They've won a number of awards, but it's because she made the investment in the organization. They have a foundation in innovation, and we're very fortunate to have met them in our journey. And I'll tell you a little bit about that, because working together with them made all the difference. And I think that's part of when you're trying to implement anything, you have to have the right partner. Our company, Steve Riley, I'm the CEO and co-founder of Mednition. Our company was founded out of a real event with my daughter in an emergency room that didn't go well. She's fine now, but in sitting with that organization, I understood that clinicians struggle every day, and it's now worse, to make the best possible decision for the patient that's in front of them. And we sat back, and we have an amazing team, and people like Dina, who we're so fortunate to join with us in this mission, to say, how do we support clinicians to make the best possible decision? And if you're going to make a clinically accurate decision, it can't be biased. You have to address all of those things. And what we're going to talk about today also is that addressing equitable care is also really great for the hospital. It improves throughput. It actually improves profitability. I'm not sure if I'm saying something that y'all don't know, but what we see is when you can address putting a patient on the right path as early as possible, everything gets better. Everything. And that's really exciting because we've seen some fairly remarkable results. We're now the standard of care at Adventist Health. We have a number of other systems that we work with throughout the country, including someone here local, LMH, Lawrence Memorial Health, which we're very proud of. Erica Hill, I think, is here somewhere, Tina. But a little bit about us. So we believe that given what's going on in the current environment, it's never more important to support your clinicians. And so we developed Kate AI to sit on the shoulder of every nurse, as Mara said, and to provide clinical guidance, clinically accurate guidance to them as to what is going on with the patient in front of them, to help them see the patient for who they are, not what zip code they've come from or other things. So we removed those things that can cause bias in modeling, which I've spoken to many of you about in the last day, so that we can provide that clear and accurate clinical guidance. Right now, nearly 150 million people go to probably now less than 5,000 emergency rooms around the country. That's more people going to less places that are staffed even less pre-COVID, that are also have fewer people and less experienced staff. So when we developed Kate, we knew that we had to really work closely with our hospital partners. We had to be transparent, and we had to team with them so that whatever we developed worked, but it worked in with already what they're doing. And we think that's the real recipe here, is that when you're going to do something like this and you're going to try and affect care and the outcomes that we're going to talk to you about, it has to be try and integrate it into the process of whatever you're doing, because then it will just happen. And then you can impact a fairly large population because it's just what they're doing, because everyone is fairly overworked right now, as we all know. I'm going to turn it over to Dina, my Chief Nursing Officer, and we're going to tell you a little bit about what we've done. I tried to include a picture, Dina, of us standing in front of White Memorial at the end of 2018 when Kate first went live. But sorry, Dina.
Oh, no, it's all good. That was after pushing computers around for a month. I didn't know I was IT. Anyway, welcome, everybody. I'm going to talk to you a little bit about why this is so important, and then we'll look at some data and outcomes that we're seeing, and really their windows of looking into what's going on in the emergency department and how you can use that data to improve equity. So we know that healthcare is different. Healthcare is different now than it was 5 years ago. We have increased complexity in our patients. Our nursing workforce is less experienced, and that creates this gap. And that gap, the bigger the gap gets, the more of those preventable errors get to the patient. When I'm triaging patients, the ED nurses were only about 60% accurate overall. And when you think about what bad things happen when I don't get this right from the beginning, sometimes it's an unfortunate event for a patient. It may just be delay of care. But how can we help identify those patients that are high risk without any, minimizing the bias as much as possible? When we trained Kate, we used just age and gender. There were no other identifying information about our patients in our training set, and that was intentional. And then we actually do some exercises to validate that we were able to keep the bias to a minimum in Kate, and we're going to walk through that as well. So how Kate works is Kate works in the background. The nurses don't see anything differently than they do now. The patient arrives into the emergency department, goes through that triage process. The nurse does their assessment, documents their assessment, makes their decision. We take everything that they document at the time they do their assessment, including free text, vital signs, anything that they're clicking, plus all the history that's in the record that I have 3 minutes to make a decision in the emergency department for triage. I don't have time to read 7 screens worth of history. And when you ask the patient, do you have any medical problems? There's a whole host of reasons why I don't always get the information I need to make the right decision for the patient. We use all of that to make 2 predictions about each patient, one about ESI acuity and one about sepsis. If Kate and the nurse agree, nothing happens. The patient goes to the next place, the nurse goes on to the next patient. But if there's a disagreement, we send the nurse a message in about 5 to 8 seconds from when they finish their documentation. We ask them to read it, to apply it critically to the patient, but they have the ultimate decision-making authority because the patient's in front of them. It's like a tap on the shoulder, hey, take another look at this. So when you're looking at this 29-year-old female who comes into the emergency department complaining of fatigue, malaise, headache, general body aches, and that she's 3 weeks postpartum, the nurse documented the note, documented the vital signs, assigned the patient an ESI 3, which means that they need some resources in order for us to figure out what's going on with them, but I'm not worried about them decompensating in the emergency department. We took all that information, and in about 5 seconds, we sent the nurse a message, hey, hold on a second. You said the patient's a 3. Kate believes the patient should be a 2. Kate's very confident, that's that graph, very confident this is a 2. Not only does this patient have a high heart rate, but this patient has possible preeclampsia. We just submitted a study with the Emergency Nurses Association looking at how accurately do ED nurses in 16 emergency departments across 3 states recognize preeclampsia. And I am here to tell you, we only get it right 20% of the time. Yeah, yikes, yeah, that's the best word. And so using technology like this allows us to remind the nurse in the moment, because honestly, that blood pressure, best blood pressure I've seen all day in the ED. So when you think about it from a human factors perspective, the brain doesn't always put that blood pressure in the context of this patient together in the moment. And so being able to recognize that in the first 5 minutes that I'm in an emergency department really allows the team to then provide the care that's most appropriate for the patient. So on this health equity journey, I talked a little bit about how we trained Kate, and this is how we validate that Kate did a good job. And so the first thing we do is we look in places where we know there's evidence of bias in healthcare. And in the emergency department, women who come to the emergency department with chest pain are more likely to be under triage than men. When we looked at 14,000 patients, we found that it was 34 times more likely to be under triage compared to men. Kate got 99.6% of those patients correct. So that's that opportunity when I'm triaging a female, maybe she's 70 years old, maybe fatigued, a little short of breath. Kate's going to remind me in the moment that this patient is high risk. I still teach ACLS and PALS and all kinds of other classes. And, in ACLS, we're still teaching atypical presentations for MIs. There are no such thing as atypical presentations for MIs. What we learned, clutching my chest, diaphoretic, nauseous, pain radiating, that's what an MI looks like in a white male. And that's what we've been taught forever. And so what we want to be able to do is look at patients and help nurses figure out in the moment that this patient is high risk for having a cardiac cause of their chest pain. Doesn't matter what they look like or where they come from. And so we're able to do that. Then we look in a place where we don't expect to see gender bias. And we have a clinical team of emergency nurses, providers. We meet every Thursday. We said, we're not biased when it comes to stroke presentations. And why we were wrong. We actually found that women were 20% more likely to be under-triaged than men who present to the emergency department with signs of stroke, which was really surprising to us and wasn't as clear. We did look, and some studies said yes, some studies said no. But Kate got about 97% of those patients correct. So again, that opportunity to correct in the moment. The value of being able to look at your data in the emergency department is pretty tremendous. And so we know that nurses are biased. We bring implicit bias to our decision making. We all do in healthcare. And so we're able to look and see where some of that exists. So I'm going to show you race related, but I'm going to tell you a story just about implicit bias in general. We had an emergency department, 75% of the patients who got admitted for STEMIs, for any acute myocardial infarction, were triaged correctly. 25% were not. So we wanted to understand what's going on with that 25%. So the first thing we did was we looked to see how many nurses were under triaging those patients, and it was 80% of the nurses in the department. Okay, this is a team opportunity. That's great. That's what we're looking for. We're looking for places where we can do some education and help improve care. So when we looked at the patients that got admitted, overwhelmingly the patients that were under triaged and then admitted for MIs were NSTEMIs. Well, now we're getting somewhere. Now I got to focus on the NSTEMIs. We looked, were we under triaging females more than males? No, the answer was this was not a gender thing. We started looking at documentation, individual triage notes, and we saw the same thing over and over and over again. Normal EKG, EKG normal. So my brain is thinking, oh, the EKG is normal, they're not having a heart attack, they're not high risk. But the reality is an EKG doesn't rule out an MI. And so that little piece of information is the piece of information that the team needs to be able to learn, to be able to do better. And so the ability to see that in the data really allows us to accelerate that improvement of care without doing what we would normally do. Is we had a bad outcome, and so now every patient with chest pain is an ESI2, and everybody has to do an hour of education, and that hour of education probably doesn't contain the information I just shared. So really spending our time focusing on the things that are important and that can really drive improvement, and not spending time having that response to an outcome because I can't see what the actual challenge is. So I promised some data. So these are the female patients we talked about, the 34% of patients that were under triaged. And what you're looking at on the left-hand side is where the nurses initially did their triage acuity, and then they got a message from Kate, because these are all under triage patients, and then where they landed. So on the left is their initial decision. On the right is anything influenced by getting a message from Kate, same patients. And when we look at this data from a race perspective, which is one of the lenses that we have the ability to look at, we do see a population of women who are more likely to be under triaged than any other female. And that gives us that opportunity to intervene, to educate. The other interesting thing is that the nurses are responding, and the rates in which they're responding to Kate don't seem to be tied to race, which is great. They're taking that clinical information, they're applying that clinical information. So it shows us where that opportunity is. But then if I look at patients who come into the emergency department who have stroke signs, again, women with stroke signs, the population of patients that I was under triaging for MI, I'm doing the best at for stroke presentations. And one of the things that we've learned as we've worked with our hospitals is even in a region, hospitals that may be 10, 15 miles apart, the opportunities for improving equity are different in each emergency department. And while all of us come to work to try to make the best decision possible for the patient, when you ask us to change, we can be just a little bit stubborn about that. A little bit. And so bringing that data into the clinical, to the clinical leaders and then to the nurses at the bedside and the providers at the bedside, we could really see, oh, you know what, we do have an opportunity. 80% of us are doing this. Let's fix this. Let's get together, let's fix this. And then we can move on to that next opportunity and measure that improvement. So Mara talked about wanting to look at patients with sepsis and wanting to look at that from a race perspective. And we did real quick for her, and what we found is we're doing a great job. The nurses are doing a great job equitably identifying patients who have sepsis, which is fantastic. So even though it's on the list of things that we want to work on, it may not be the thing that we need to spend most of our time in, which is fantastic. So when we look at using AI, and Steve mentioned the transparency piece, we have to be transparent, right? You shouldn't, if you're going to bring AI into healthcare, what's the model supposed to be doing? How well is it doing it? And then how do we integrate it in our workflow so that we don't even notice it? It just works. And so we wanted to see how Kate was doing, letting the nurses know about patients who might have sepsis. And so on the left here are patients that Kate alerted on, and it's percentage of patients by race. And it looks fantastic. And then you look and you go, wow, patients of Asian descent, they get a lot more alerts. What's going on? Then you look at the right-hand side, and that's patients who were diagnosed with sepsis. And there you see that Asian patients have, they're almost twice as likely to be admitted, or almost twice as many patients are admitted for sepsis. So we're not biased in the alerting. We are diagnosing sepsis in that patient population more often. And so to share that data with Mara, with the team, so that they can really focus on the things that align with their strategic goals, but also where the opportunities truly are, and then understand them enough from a clinical decision perspective to provide interventions that really work, measure that improvement, move on to the next opportunity, and celebrate the things that, like sepsis, that they're doing really, really well. So how does Kate fit into a continuous improvement process, especially around equity? The first is having a framework, and I think Mara talked and beautifully about that they're shifting their strategic planning focus and really bringing a DEI lens into that. We identify those areas of opportunity so that we can improve equity at the front door. One of the questions we get messages from nurses. We have a feedback mechanism, so any nurse can send us a message about any patient question, and we answer every single one. And so we'll get messages. Well, Kate said this patient should be a 3, but they're really a 5 because they're here all the time and they just need a turkey sandwich, which is the universal meal we serve in emergency departments. Well, Kate's going to look at that patient as if they just walked in the door for the first time every single time. And so it really helps to remind me that this is a human in front of me and that they are here for care and not necessarily just for a sandwich. So really, again, being able to use that data to identify areas of opportunity so we can make better decisions. Using the data from our clinical data engine and really being able to again, measure those improvements, slice the data in any different way. You want to look at women, you want to look at pediatric patients. I want to look at all kids less than between 2 and 5 years old who come to the emergency department who have asthma. And I want to see how well they were triaged, were they triaged equitably? And I want to look at that from an ethnicity lens. I want to look at that from a race lens. I want to look at the patients that are unhoused. I want to look at the patients that don't have primary care. And really, again, be able to see where opportunities are. And then putting that focus to set that intervention, the intervention that really works to solve the problem that you're trying to solve. Doing that education, and then going back and measuring, did we make an improvement? Where's our next opportunity? So all ways in which we can use data and support clinician decision-making in real time using AI to help improve outcomes for patients. So I am going to turn it back to Steve.
Say, can I have questions? Yep. So we've gone through a lot, and some of the takeaways were, obviously, as Mara has spoken, is community engagement is absolutely key in understanding your community. A data-driven approach. We're a data organization, and only being able to see it are we then able to react and respond to it, including committing to that continuous learning. When we developed Kate, we spent 1.5 years working with clinicians, and we said, what is it that you need? We're starting with a blank slate. And they said, stay out of the way. Let me know when I'm about to make potentially a life-changing, unfortunate decision for one of my patients. Help me to learn, not through the normal method, which is through experience. Let me learn from other experiences. And take feedback. Continuously learn, so that Kate is part of the team. Just Kate never forgets. But Kate's always striving to get better. But Kate is a vehicle for us to share our experiences in. And why we were so excited to be here and share, aside from, Dana reaching out to us, was that we're incredibly passionate about seeing things sooner and getting the patient on the right path. And when we built Kate, we struggled for years to get Kate to be accurate. But then when we really started to address and build our models and pull the bias out of them, we started to hit the levels that we really needed to hit. And so we truly believe that equitable care, making the right decision, you have to be equitable. And also then what we see in all of our hospital partners is that things just get better. Throughput gets better. Reimbursement gets better. Everything, because a patient's on the right pathway. So if you have to build the quality in up front if you're going to use AI. You have to have an amazing team, which was the team at White Memorial at all levels. The nurses were phenomenal. The doctors were phenomenal. Our team, the support of the AHA, and then you can really take something forward where you can make a difference in a very large population, because it's only getting worse in emergency rooms around the country. I know many of you hear from a lot of systems that we're probably speaking to already. It's a challenge. The front door of the hospital is a significant challenge right now, but if we can address that, then that patient travels down an entirely different path. And that's what happened to my daughter, unfortunately. But we're here to solve that problem now. And so thank you all for being here. Sorry about some of the technology challenges. And we're here to answer any questions that you may have.
Sure.
So many questions. I have so many questions. Okay. So I guess 2 questions. One is, AI itself can be racist. Mm-hmm.
Yep.
Yes.
Hear about your process and your team.
Sure.
And how you put together diversity.
Go ahead.
And I'm also curious, where did the name Kate come from?
Well, we'll start off with the easy one first. Kate is not an acronym, but I will tell you that people have come up with acronyms, some of them highly creative. Kate is actually the name of my daughter. So.
Yeah. So as far as how we train the model, so first and foremost, we were only using age and gender. No other identifying information, no social determinants, nothing. Just what we use is what the nurse documented, the vital signs, the history that the nurse had available to him or her at the time. And that's it. And that was intentional. So Kate doesn't understand color. Kate doesn't understand the concept of race. When we bring our clinical team together, we actually have a blinded process to label cases or assign the right acuity. So I have a partner. I don't usually know who my partner is. We created a web app so that we could do this from anywhere. So I get 100 records. My partner gets the same 100. We independently go through and we label our cases. Anything we agree drops right off. Anything we disagree goes through a Delphi process. When we're done with the Delphi, anything that we agreed drops off. Anything we disagree comes to clinical. And that's when the fun starts. And so we try to get, 10 emergency nurses and emergency providers to agree on one patient. Because how much fun that is. And so what often happens is we can all argue a different acuity based on the documentation. And so then we'll throw the case out. We won't use it for trading. Anybody, even our engineering team, can say, delete. Because we get a little, not that we get heated, but we start to miss the documentation that should be there to be able to do that. So that's an ongoing process. We still meet every Thursday. We still label case. We have a batch out right now. And we even go back. There are times when we're doing a model run and Kate will spit something different out, right? She'll make a different prediction. And we'll go and we'll look and we'll realize we messed up. Because again, we're human. And so you've got humans teaching the AI. So our team will give us the same cases we've already looked at. Like in a year, I might see 5 cases from a different batch again, just to make sure we have inter-rater reliability in that process of labeling cases. So it's really about supervised learning. We just don't let Kate go do her own thing. But if we only gave Kate nurses' notes and didn't go through the validation process, Kate would only be 60% accurate. And then, yes, I can talk about, how patient fell down the stairs, is unresponsive, but was drinking. ESI 3. Okay, I see it right there. There's the bias. It's screaming in the documentation. So we don't want to teach Kate with those records. And so if we see those, we'll just delete them in our training set. Great question. Thank you.
Thank you. First of all, this is amazing. And I'm sure it's already saving incredible amount of lives just in your area. I come from a very rural area, and I work in very rural populations. Some extreme examples are I have a county in my state that doesn't even have EMS because it can't find somebody to contract. So their EMS times for some of their people, what they do is they have on file the addresses of those members in the county, and there are plans to meet halfway with EMTs. So I'm curious if y'all have plans to try this out in an EMT setting. Mm-hmm. And then also if you have plans on somehow trying this out in rural areas where sometimes there are only 2 people on staff in a ER situation, and one's a nurse and one's like a lab tech, so to speak. Yep. So
second question first, our smallest EDC is 8,000 patients a year. They're a federally qualified critical access hospital. We actually have 3 of them that use Kate. And so developing Kate was really about something that works. This wasn't something we developed in an academic medical center that only works in an academic medical center. Our smallest EDC is 8,000 patients a year. Our largest EDC is almost 100,000 patients a year. We're in rural settings where I don't even have, my phone doesn't work when I'm up there, which I love personally. But not great. As far as EMS, I'm glad that you brought that up. We are actually doing a research study with ESO, which is one of the largest EHRs for EMS providers. We want to see, first of all, if we can help them identify high-risk patients. We also are looking at, if we're using the data that's coming in live from EMS, can we help the nurses make better decisions as well? So kind of both ways. Yeah.
I mean, it's something we're
excited.
It's something we're really excited about, and so are they. Again, if you think about it, the basic platform is, can we move this out to the earliest point in a patient's journey? Can we help those clinicians make the best possible decision? And then what can we do en route? As you said, sometimes it's a fairly long transport time. Obviously, some cities it's not. but it can mean all the difference. So we're excited about that, and we're hoping to be done with the research here shortly.
I heard you say earlier that Kate looks at like the history of the patient, like previous records. Does Kate have access to records from other facilities? Because we know that patients go to multiple EDs. So how are you getting that data? Is it only from the ED they're in, or are you able to get that from an HIE or something else to better make a decision?
Great question. So in a system that got multiple sites and you're using EHR, we get the history that's tied to the medical record number. So it doesn't matter where they were seen, we get that. From an HIE perspective, yes, we can, but we have yet to meet a hospital that pulls that data in before triage. So we're happy to, and we get excited anytime somebody asks us. We want the data. We want the data. We're doing an implementation in New Jersey right now, and they asked us that question. We're like, absolutely, and then they're like, yeah, we don't pull it in until the provider sees the patient. Okay, well, if you did, we could use it, but yeah.
Hello, I'm Rosangeli Cruz from Mainland Health. Really impressive. I was interested in looking at if you're looking at some metrics to see success over time, let's say ED returns or reduction of readmissions, just to see whether the effect is on both sides, because some of the examples you provided were patients that might have been triggered and not catch, but what about the other side of the coin?
So I'll give you a sepsis example. Adventist Health as a system has a 1-hour bundle in the emergency department, which some emergency providers say that's the way to do it, and some say, no, we don't need to do that. So I'm going to talk about a 1-hour bundle. What we're able to do is help them identify twice as many patients at the front door than the source of infection and 2 SIRS vital screening that we're using kind of universally in the emergency department. So once they started using Kate to start their sepsis response process, not give everybody antibiotics that Kate said, but that they start that process, not only did they improve their time to first intervention by 28%, but they reduced their excess GMLOS on the inpatient side for MSDRG 871 by a full day and 872 by a half a day, simply by taking the administrative burden away from nursing, where I don't have to fill out the piece of paper to screen everybody, and using Kate to start their screening process for sepsis. Nursing satisfaction goes up because they feel like somebody has their back. ED length of stay, when nurses are adjusting acuities, length of stay goes down, which is also fantastic. My favorite is we had, change is fantastic, but there's always a handful that don't want to do it. No matter how great it is. In our Adventist White, we had a nurse she's the only nurse that figured out how to work around Kate. And her workaround you can't do anymore because Cerner got rid of that little thing. But she figured it out. So that's the first 6 months were like that. So a year and a half later, she pulled her manager aside and she said, first of all, the sepsis thing, best thing we've ever done for our patients. But I took a triage test in my other hospital and I got 100, and it's because of Kate. And so that education piece, that really being able to help nurses elevate their practice, then carries with them to where other places they're going. So we do look at all kinds of outcomes related to care, great catches. I was working with an organization where there were 3 patients in 3 months that they had called back that were under triage, that Kate sent the nurse a message and the nurse was able to change their trajectories. And one of those patients was in severe sepsis. So those are the ones that are harder to measure, because it's hard to measure something that didn't happen. But when you sit down and you look at those records and go, oh my gosh, I can't believe that we were to under triage those patients, knowing that that diagnostic momentum, the decision I make at triage, carries through the patient visit, the number of times that the nurses have corrected trajectories of patients that absolutely could have decompensated, especially at some of our EDs that have hours-long door-to-provider times. Those are the cases that we can thousands, hundreds of thousands at that point of those patients that we've been able to help the nurse identify and adjust. But there's no magic measure for that, unfortunately. But that's the doing the right thing part.
Yeah.
This sounds really amazing. Thank you so much. Great impact clearly on nursing. I'm curious, how has all this affected your providers and your clinicians? I'm just curious.
Great question. So it's funny because when we went live with Kate, some of the feedback we got initially was actually from the providers. The first thing they said is, I'm not trying to chase somebody to repeat an abnormal set of vital signs, an obviously wrong set of vital signs before I discharge a patient. Because if I accidentally at triage put the respiratory rate in the heart rate box, Kate's going to send me a message, go, dude, your patient's dying. And that I look and I go, oops, because typing, talking, and tabbing were always faster than the computer. So those errors that were driving the providers crazy because they just had to find somebody who just delayed discharge, it's the first thing they noticed. Second thing they noticed is they could actually tell what was going on with the patients in the waiting room because there were objective assessments on the patients. Because ED nurses were just a tad competitive, a little bit. And what they learned is if they documented the objective assessment that they did, which is what we should have been documenting all the time, they get more accurate predictions from Kate. Kate sends the messages less often. And so that objective documentation is there. And the third thing is standardization, that it doesn't matter who's out in triage now. If the patient's 2, there are 2. And that really was the original goal of us bringing Kate in, was to help standardize the acuity assignment. But those are the 3 things that the providers most often. Sepsis, I have providers that tell me they can't do sepsis without Kate anymore, because Kate sees things in patients as, a 75-year-old that comes in new onset AFib, that Kate says sepsis, and they say, yeah, it's cardiac, and they go down the cardiac pathway, and they're 3 hours in, the chest x-ray is bilateral pneumonia, now they do the lactate, it's 4, that Kate saw that 3.5 hours ago. And so every single time a provider has a patient like that, it's that believer thing, like I need Kate to help me identify patients that I need to consider sepsis in that I never would have considered had sepsis before, and they do have sepsis.
And I'll say that providing the data and sharing that data that we shared with you, because basically we give you back your data in a format that you can use just like we use, that usually starts to address some of those concerns that they have. And if they're not on board, maybe a month in or 2 months in, we'll do a comparison, and usually they're on board at that point.
My favorite comment about nurses that use Kate is, Kate, I'm fighting with Kate. And to be fighting, I'm a clinical nurse specialist by background. So to fight with Kate, it means I made my decision, I understand my rationale. Kate made her decision, and I understand Kate's rationale, and I have to reconcile that in the moment. And that's critical reasoning, right? That's what we had it, and then we went to electronic health records, and we stopped talking to each other, and we became very task-focused. So Kate stimulates that critical reasoning, which the providers will tell you is not just at triage. And so there's more meaningful conversations happening about, anticipating the plan of care, what am I worried about, and being able to articulate those things that didn't exist before Kate, unless you went back, 10 years before then.
Sorry, go ahead.
Sorry, I have one more question. Have y'all done a financial analysis on how much money this is saving hospitals?
We could do that one.
So we actually left that up. We left that up to our partner hospitals. Every hospital is a partner. We exist to serve, basically. And the basic point was Kate has to pay for herself. By the way, Kate's not expensive. You can't buy anything in Starbucks for what Kate costs. I mean, it's less than that. Because Kate was designed to help everyone, to be at the rural hospitals as well as our large urban. But what we found is that Kate has a very large ROI. What we see is that patient with the documentation correctly aligned right from the start, moving through, reimbursements are much higher. In a study that was done by one of our partner hospitals, they saw a fairly dramatic increase, 5% in reimbursement. They saw if you're all familiar, the Emergency Severity Index, there's that 2-3 boundary that Dina's been talking about. That's like the DMARC for high risk. A lot of patients are just put back out in the waiting room or sent to fast track or sent home, and not intentionally, but that's just sort of the environment and what happens, what we've talked about. When you see them clearly for what's going on and you identify them as high risk and you put them back, just on that 2-3 boundary, hospitals are picking up $140 a patient when you look at what Dina talked about from sepsis standpoint, in many hospitals and many EDs, and these are not large ones, it's $1 million a year, in savings. So when I said early on, doing the right thing, equitable care actually makes the hospital money. I mean, I'm just putting that out there. Like, this is let's do the right thing as early as possible, and that'll take care of any questions with the CFO.
Just curious how these CAHs would have survived in rural areas if they had had Kate 5 years ago.
Yeah.
Just throwing that out
Yeah.
there. The amount of closures in CAHs. This is game changing.
Yeah. Thank you. Thank you. Yep.
Yes.
This is a totally selfish question, but thank you for your presentation and for developing this. The PowerPoint that was shared doesn't have all the slides that you shared. Are you able to share all of those slides?
Yes.
Yeah.
100%. Sorry, given the video and everything that we did last night and this morning, which you saw, we had to put some stuff together. So,
46, we were still troubleshooting.
we will get you. Matter of fact, I'll scan your badge or take a picture. I will email everyone everything that you just saw.
Some of these slides that were up there look very intriguing, and I couldn't really read them.
Sure.
Yep.
Yeah. No, we'll share everything with you.
If you want the slides, go see them and they'll get your email address. Okay?
Yep. And we're at booth 26. When you walk in, we're to the left, next to the spinning wheel, which I know a lot of you have done this. We're right next door. So happy to answer any other questions that you have. And thank you for getting up early this morning and joining us.